Hello, sorry for the delay. I'm Dr. Pushpa Singh, chairperson of the NCD committee. Sorry for the delay because the resource person cannot get connected because due to high demand. So you have to bear with us for some minutes.
Hi, Pushpa, I managed to log in.
Right. Okay. I don't know whether Sunet got corrected. I don't know whether Sunet got connected because he also got cut off.
I think he had to log out to get me in, I think, but let's try to get him in, isn't it?
Yeah, right. Okay. So anyway, so shall we start, Chamara? Oh, I don't know whether.
Yes, I think in the interest of time.
Yeah. So good evening, everybody. Welcome all of you to the webinar Fresh on the ECG. The webinar is organized by the NCD Committee of the College of General Practitioners of Sri Lanka. And I'm delighted that over about 400 had registered for the webinar by today. But unfortunately, we can accommodate only 100 registrants. So don't worry that we'll be sending the record tomorrow for all the registrants. And I thank Dr. Chamara Ratnayake, who readily agreed to be the resource person today. And he has been very accommodating to our request always. And then I thank our moderator, Sunet, who is the secretary to the NCD committee, for helping me to organize this webinar. And over to you, Sunet, to introduce Chamara, if Sunet is there. Is Sunet there? I don't think so. Chamara, I will introduce you. So Dr. Chamara Ratnayake is a, very popular cardiologist in the private sector. He is working in the Asiri Surgical Hospital and Asiri Central Hospital. He readily agreed to be the resource person, and he is a very popular cardiologist. So over to you, Chamara.
Thank you very much, Dr. Pushpa, for that introduction. I don't know whether I'm popular or not, but I...
You are popular. You are popular.
Thank you. Thank you. Very kind. But anyway, thank you very much for inviting me to give this lecture as well. And thank you to Sunet. Unfortunately, I think he had to log out to accommodate me into the lecture. But I'm very pleasantly happy and surprised to see the popular demand for this lecture as well. And I suppose it's an important one for everybody. ECGs are obviously things that we encounter day in and day out in our practice. So I think it's it's definitely a good idea to learn a bit more, and we learn every day, even as cardiologists. With ECGs, it's something that we are always obviously learning, and it's something that fascinates us as well. So what I thought was, so when Sunet asked me to talk about ECG, he suggested that the topic of a fresher on the ECG. So I think the best way to learn and to talk about ECGs is when it's case-based. So, real life scenarios, for example. So what I thought was I'll base my lecture on a case-based manner, so that it'll be a little bit more, I suppose, practical in that sense. And also, if there's any questions, and Dr. Pushpa, if you are, I suppose you will have to do the moderating today for this. I'm more than happy to be interrupted in the middle of the lecture, even if anybody has questions or anybody has to wants to raise their hands and ask questions. No issues in interrupting me. And of course, I will try to keep this as short as possible, because I know when it's to do with ECGs, it generally generates a lot of questions at the end as well. So I'll try to keep some more time to answer any questions that anybody in the audience will have. As far as any conflicts of interest, I don't have anything to declare, except for the fact that I'm a cardiologist and I like ECGs. So that's kind of I'm kind of biased towards that, I suppose, but I don't have any other conflicts of interest. I do like a little bit of history, though. I just read about things, and I just like to read about different things in medicine and the history of medicine. So it fascinates me sometimes. So just a quick word on the ECGs as well, and just how it came about. So in the late 1800s, a chap named by the name of Augustus Waller, he was a professor of medicine in London, St. Mary's College in London, St. Mary's Medical College. He's the one who first recorded electrical activity from the human heart. And the first EKG, the term of EKG was coined in, again, 1893, late 1800s. And in the mid 1950s, 1954, as you can see in this graph here, right at the end, it's when the first 12 lead ECG as we know it, the one that we record now, was introduced. So it's been there for a while. 1954 means a good, it's so exactly 70 years, isn't it, to the day, to the year rather. So it's quite fascinating as a simple ECG, which has been there for about 7 decades, is still something that we are using day in and day out, which is bread and butter for us sometimes. And it's been there for over almost 70 years rather. So it's something very, very fascinating. And so this is just out of interest. This was how the first ECG was taken. Quite fascinating, isn't it? You can see the picture on the left. That's Augustus Waller himself getting an ECG of his own. Look at the size of that contraption that he had to get an ECG done. And when you compare that to the ECG machines that are used nowadays, you can see what a difference time has made. But the interest was fascinating. And obviously his contribution to medicine is immense, because it's, ECG is such a simple investigation, let's say, but it gives us so much of information. And obviously it's a matter of, and it could be a matter of between life and death as well, obviously, isn't it? When it's an ECG and you diagnose a condition, for example, a myocardial infarction, definitely a matter of life and death, because if you initiate treatment early enough, it will save a person's life. So it's definitely something fascinating. So what I thought was, I'll just tell right from the get-go the things that I will not cover in this lecture, because it's such a wide spectrum of things. When you talk about the ECGs and everything, it's a lot of things come into mind. So I'm not going to talk about how to take an ECG. It's definitely not within the scope of this lecture. I'm not going to talk about ECG leads and the basic properties of an ECG, the Q waves and the P waves, etc. I don't think that's going to be part of the scope of the topic. And at this level, I think we should all know about the ECG. And I will not talk about, the ABCs of how to interpret an ECG, but I thought, as I said, it's going to be more case-based, and I'll obviously try to make it practical and give you some ECGs. And unfortunately, I'm sorry, I do apologize. I will not give my number at the end of the lecture to send uninterpretable ECGs. But things, when it comes to general practice, and I believe all or majority of the audience here are general practitioners, I think there are a few important ECGs that should not be missed whenever you take an ECG at your practice, or a patient comes in to your practice with an ECG. And the two main I suppose diagnoses or diseases that you should not miss are acute coronary syndrome, so both a STEMI or a non-STEMI, non-aspiration MI, and arrhythmias. So it could be either tachyarrhythmias or bradyarrhythmias. So those are the four main.
Excuse me, Chamara, that your voice is not loud enough, it seems.
Okay, I'll try to talk a bit louder. Is that okay? Is that better? I hope so. Loud and clear,
Not
Pushpa?
to me, but not to me, for some participants.
Okay. Can you hear me quite okay, or is that okay for you?
Yeah, you are okay for me.
Okay, fine. I'll try to talk a bit louder. I'm sorry. I do apologize. So the important, again, from as far as ECGs are concerned, I think from a general practitioner's point of view, I think it's important. Certain ECGs should not be missed. And these are the acute coronary syndrome ECGs and arrhythmias. And there are certain ECGs, whenever you get one or you see a patient with a certain ECG, there are certain ECGs that mimic these conditions as well, acute coronary syndromes and arrhythmia. So such as bundle branch block, ectopics, J-point elevations, isolated T inversions, symmetrical T inversions, etc. So I will talk a little bit about these ECG mimics of acute coronary syndromes and arrhythmias as well, because those are the ones that kind of a bit more difficult to interpret maybe, and those are the ones that sometimes we scratch our own heads. Sometimes as cardiologists, as ourselves, we can be sometimes fooled by these ECGs as well. So I'll try my best to try to navigate through these ECGs that mimic acute coronary syndromes and arrhythmias as well. But the most important thing, and this slide is something that I use in most or all of my lectures. Those who may have heard me speak before as well would have seen this slide, but it's one of my favorite quotations ever in medicine. So it's the same for an ECG. As we all know, ECG is an investigation only, but that cannot ever overtake the importance of the medical history. So Sir William Osler, obviously you would have heard about him, is considered one of the fathers of modern medicine. He said, listen to your patient, he is telling you the diagnosis. So sometimes we don't even need the ECG to know if a patient is having some sort of a problem, as from a cardiac point of view. If it's a myocardial infarction, they give a classical history sometimes. So the ECG is only an ancillary investigation that helps with the diagnosis. So listen to your patient always. Even in your practice, before taking the ECG, get the history, the correct history, and ask the patient to talk to you and relay the information. What type of a chest pain is it, etc. And that piece of information is worth its weight in gold, because that will give you a diagnosis even before you take the ECG sometimes. So listen to your patient. He's telling you the diagnosis. Please remember that quotation, and always get a good history before you proceed to taking an ECG or looking at an ECG. If a patient comes to you with it, take the history first. That will give you a very good idea, because sometimes the reason I say this also is that, as I said, there are certain ECGs which can be very difficult to interpret maybe, and there are certain ECGs that can mimic certain diseases such as an acute coronary syndrome or an arrhythmia. But if you listen to your patient and you have got the history in your head already, that will definitely help you in a long way in the interpretation of the ECG as well. So listen to your patient. That is very, very important. So let's talk about a patient. So as I said, this is going to be a case-based discussion. First patient is a 60-year-old diabetic who comes to the general practice with a 2-hour history of central tightening chest pain associated with sweating. So you can see the history there itself, isn't it? That sounds like it's a ischemic sounding chest pain, if I were to say it in any other way. A central tightening chest pain associated with sweating in a diabetic patient. So ischemic sounding chest pain. His vitals were fine, blood pressure is good, heart rate was 90, and an ECG was done. So this was the ECG. So again, as I said, I'm going to just run through the ECG. I'm not going to talk about the A, Bs, and Cs of an ECG, but when you see this ECG, there are certain obvious changes. And again, the thing with ECGs is that it's more or less what we call spot diagnosis. When you see it, you see it. If you don't see anything, more often than not, it is a normal ECG. So what is the more obvious thing that you can see? So if you go through the basics of ECG, you see that it's a regular rhythm. There are P waves. You can see, hopefully you can see the pointer here as well. There are P waves in front of the QRS complexes. So that means it is in sinus rhythm. But what is the most obvious abnormality here in a patient? So you remember the history as well. It's a patient who has had ischemic sounding chest pain, a diabetic patient. So you're in your head, you're thinking, is this an acute coronary syndrome? And if it's an acute coronary syndrome, is it a ST elevation myocardial infarction or a non-ST elevation myocardial infarction? So that should be the thought process in your head. So yes, do we see ST elevations in this ECG? Yes, we do. So where do we see it? So the next question that you ask yourself is, where do you see these ST elevations? So if I were to point towards certain ECG leads that you can see ST elevations, you can see it in lead L1 and then in lead AVL. And then when we go to our chest leads, you can see it in lead V1, 2, 3, 4, etc. So we can see ST elevations in lead 1, AVL, V1 to V4. So the important thing here, when you see ST elevations again in your head, next question is, okay, so is this a STEMI or not? Is this an ST elevation, myocardial infarction or not? So to answer that question, we need to know how to give an ECG diagnosis of an ST elevation myocardial infarction. So I'll give a slide on this as well, but the important thing to remember here, there are certain points to know what is the diagnosis of STEMI on a ECG is. The shape of that ST elevation, we call it concave. I'll go back to that ECG as well to show you what I mean. So concave as opposed to um, uh, I'm sorry, it's not concave. I'm sorry, I should change that actually. It's convex. I do apologize. Convex shaped ST elevations. I do apologize there, a bit of an error on my part. Convex shape, so as opposed to concave. Convex shaped ST elevations are the hallmark of an ST elevation myocardial infarction, convex shaped. I'll show you the shape of the ECG as well. And the ECG should have ST elevations more than 1 millimeter or 1 small square on the limb leads or more than 2 millimeters in the chest leads. And these ST changes should be seen in more than one contiguous lead. So contiguous leads are not continuous leads, but they are ECG leads which points towards a certain territory of your heart. So as we all know, we have certain territories. We have the anterior leads, we have the inferior leads, we have the lateral leads, for example. So these ST changes, whenever you see ST elevations on an ECG and we are thinking it's a STEMI, should have ST changes in more than one contiguous lead. And what I've highlighted here, this is probably the most important thing when it comes to the diagnosis of STEMI on an ECG. The changes of a STEMI or ST elevation myocardial infarction on an ECG are dynamic over time. And I'll show you some examples of what I mean by this. So as the word suggests, dynamic means that the ECG changes as time progresses. So let's say that a patient has got chest pain and you take an ECG at 9 p.m. and you see ST elevations on that ECG. If you repeat that ECG in half an hour at 9:30 p.m., you should not, if it is a STEMI, that ECG should not be identical. There would have been something that would have changed in that ECG. And that's the process of an ST elevation myocardial infarction. It changes, it's dynamic, it's progressive over time. And that's the hallmark of any acute coronary syndrome, be it STEMI or non-ST elevation MIs as well. The ECG changes are dynamic over time, as opposed to non-ischemic ST elevations, which I will show you some examples of. These ECGs do not change. Non-acute coronary syndrome ECGs do not change over time, but the hallmark feature of a acute coronary syndrome, STEMI or non-STEMI, is that they are dynamic over time. And there are associated reciprocal changes. So these are ST elevations will have what we call reciprocal ST depression. So these are in opposite leads, they will have ST depressions as well. And that's something very, very important. So these are the hallmark features of a ST elevation myocardial infarction. Convex shaped ST elevations, more than 1 millimeter in the limb leads or more than 2 millimeters in the chest leads, and in contiguous leads, and they are dynamic over time. So let's go back to that ECG that I showed you initially. So you can see the shape of these. You can see that the ST segment is all the way up there. For example, in this lead V2, and it is convex as opposed to concave. So convex shaped ST elevations are seen. And they are contiguous leads. So as I said, contiguous leads means they are pointing towards a certain cardiac territory. So you can see lead L1 and AVL are your lateral leads, and V1 to V4 are your anterior leads. So this is a anterior ST elevation myocardial infarction. And always remember, as I said, we need to go by the history as well. It's a clear-cut history, ischemic sounding chest pain in a diabetic patient. And when you see this ECG, you can see that there are convex shaped ST elevations in the anterior leads, in anterior and lateral leads. And again, your main diagnosis here would be an ST elevation, anterior ST elevation or anterolateral ST elevation, myocardial infarction. So the next ECG, which I will show you, is this one. Again, if you look at the ECG, from the basics, you can see that the patient is having, its P waves are there before the QRS complex, it's in sinus rhythm. But again, given that history, we are thinking, is it a myocardial infarction? And is it an ST elevation myocardial infarction or not? And we could again see quite clear-cut ST elevations on this ECG as well. And where do we see it? Mainly, and you can see in lead 2, 3, and AVF. Again, convex shaped ST elevations in contiguous leads. So this 2, 3, and AVF points towards the inferior part of the heart. So our diagnosis here is an inferior ST elevation myocardial infarction, quite clear cut. And look towards the opposite leads, what we call the lateral leads, L1 and AVL. You can see ST depressions there. So those are your so-called reciprocal changes. Again, that points towards, again, that this is definitely a STEMI, an ST elevation myocardial infarction, where there are ST elevations in leads 2, 3, AVF, with reciprocal changes in lead L1 and AVL. So our diagnosis here is an ST elevation myocardial infarction in the inferior lead. So in other words, an inferior ST elevation myocardial infarction. So this is what it looks like. What about this one? Again, sinus rhythm, but do we see ST elevations? The answer is yes. Where do we see them? We see them in lead L1 and AVL here. So those are your lateral leads. Again, convex shaped ST elevations in L1 AVL. And you can see opposite or reciprocal changes in lead 2, 3 AVF. So we see the ST elevations in L1 AVL. So this is what we call, so the L1 AVL are your lateral leads. So your diagnosis here is a lateral ST elevation myocardial infarction. So again, as I said, these are more or less what we call spot diagnosis, but remember the history was what was most compelling. And also remember, sometimes when we see ECGs, sometimes we note these ST depressions, 2, 3 AVF, and we think in our heads, okay, we see ST depression. So that's sometimes our eyes sometimes play tricks on us, where we think, okay, we see ST depressions and we are happy also in a way sometimes. Oh, I got an ECG done in this patient, I see ST depression. So it's probably a non-ST elevation myocardial infarction in this patient. However, then what happens is that you have actually missed the ST elevations in those lateral L1 AVL, because it's just 2 leads here, isn't it? So always, whenever you see patients, or ECGs rather, where you see ST depressions, just keep an eye on ST elevations in any of those, 1, 2 leads. Sometimes, especially lateral STEMIs, are things that are easily missed on ECG interpretation. So always keep an eye. If you see ST depressions, especially in those inferior leads, 2, 3 AVF, look at L1 AVL to see if you have missed an ST elevation in that. So this is what just a quick slide on the time course and what I mentioned about the dynamic nature of ST elevation myocardial infarction. So the earliest sign that you see on an ECG in a patient with a STEMI is actually not ST elevation, but this hyperacute T wave. So if you I suppose in a way lucky enough, or the patient is lucky enough that they've come in very, very early or into your practice, your initial ECG will show hyperacute T waves. And then after some minutes and some hours, you will then reach that point of ischemia where there are ST elevations. You can see in B there. And as the hours go by, you will notice Q waves forming, and that is a sign of necrosis and infarction. If I were to give a term there, that is where when you see Q waves forming, that means that it has that area of myocardium has infarcted or necrosed, and it goes on as well. And you can see the dynamic nature there. And then after a couple of days, the ST elevations have come down, and you have noticed these T waves as well. So this is the dynamic nature of ST elevation myocardial infarctions. And again, what we emphasize here, and that because of that dynamic nature of how ST elevation myocardial infarctions progress, the golden rule whenever you get a patient to your practice, or if you're having a shift in any other hospital, in an emergency unit, and this is what I always, I preach this as well. If you, especially in a patient who has a very suspicious history, where your history is quite suggestive of a myocardial infarction, and a patient has risk factors, never be satisfied with a single normal ECG. You should always repeat it at least once or maybe twice, especially if the history is suggestive, after a few minutes. And you can see the changes happen within minutes, isn't it? So sometimes the question is asked from us, when should we repeat the second ECG? Should it be done in an hour, 2 hours, minutes, etc.? So again, there is no hard and fast rule there. But even if you repeat it in 15 minutes or half an hour, 30 minutes, if it is an ischemic chest pain, and if it's an acute coronary syndrome, if you repeat the ECG in a few minutes or 15 minutes, half an hour, you should see certain dynamic changes if this is a acute coronary syndrome. So the importance of that, again, I always emphasize this, and please remember, whenever you suspect an acute coronary syndrome, never be satisfied with a single normal ECG. Always make sure that you repeat the ECG in a few minutes, so that will confirm the diagnosis. If your repeat ECGs are also normal, then generally it's unlikely to be an acute coronary syndrome. And I use the word unlikely because there are patients who have acute coronary syndromes with normal ECGs, in which case we have to do certain other investigations, including troponin I and etc. However, please remember to always remember to repeat your ECG and never be satisfied with just one ECG for your diagnosis of an acute coronary syndrome. So let's just take the same patient and talk about this ECG. So I'm just going from one acute coronary syndrome to another one. So what do we see here? Let's say that it's the same patient with that same history, and you have taken this ECG in your practice. What do we see here? Again, general thing is that it's P waves in front of the QRS complexes, it's sinus rhythm, but here what we are noticing mostly is, we can look at it in two ways. So you can see the most prominent thing is you can see ST depressions here in a lot of leads, L1, 2, 3, AVF, and then V2, 3, 4, 5, 6. So we can see predominantly ST depressions in this patient who has this ECG. But we do notice something here. If you can appreciate this, in lead AVR, there is an ST elevation which looks quite significant there, a convex shaped ST elevation in lead AVR. But majority of the ECG is showing ST depressions, and you can see the shape of that ST depressions is it's a down sloping ST depression. You can see in most of these leads, the ST depressions are down sloping, and that is significant. So this patient is having a non-ST elevation myocardial infarction with down sloping ST depression. So an ischemic ST depression is either horizontal or down sloping. Generally, most of the time, 99% of the time, if it's a non-ST elevation myocardial infarction with ST depressions, you will see either horizontal or down-sloping ST depressions. And then what about this ECG? You can see, let's say the same patient with the same history, diabetic patient with central tightening chest pain. You can appreciate, again, it's P waves in front of the QRS complexes, sinus rhythm. However, what about these leads V1, 2, 3? You can see that there is something going on there. So these are the so-called biphasic T inversions. You can see the T wave here is going up and down, so-called biphasic T inversions as well. So this is again a patient who is having a non-ST elevation myocardial infarction. The ST elevation, you can, some of you may question that there is an ST elevation there, but it's not as prominent as the others. If you appreciate, it's not more than 2 millimeters there in the chest leads. But the more important thing is here, you can see in lead V1 to V3, you can see that there are T inversions which are so-called biphasic. So that is significant as well for an acute coronary syndrome. So this is what basically an ECG, just to appreciate that the dynamic nature of what happens in patients with acute coronary syndromes. So you can see these are 4 ECGs done over almost 1 hour, repeated minutes later. And you can see the way that the ECGs can change. Here you can see in this lead, and sometimes it gets better and gets worse again. You can appreciate that, isn't it? And you can, but the important thing here is that, as I said, in acute coronary syndromes, your ECG will never be identical when you repeat it. It should never be identical. If it is identical, that means there is some change or abnormality that should not be significant. Yeah, so then let's talk a little bit about, I'm just going to skip through certain slides just for this interest of time so that we have time for questions as well. So this is a common ECG that sometimes we get in the practice as well. So you can appreciate that the QRS complexes here are broader, and I've circled the 2 main parts in the chest leads, V1 and V6. You can see that the S wave here is broad there. It's what we call a slurred S wave there. And in V6, it's more or less a M pattern there. So this is a typical ECG of what we call a left bundle branch block. And the easiest way to remember that is the so-called name William, isn't it? Slurred S, RS in V1 and an M pattern in V6. William suggests left bundle branch block. And this ECG, you can see you can notice a little bit of a different pattern there. If you look at, again, it's a broad complex ECG with a M pattern here in V1 and a slurred S in V6. So that is an RSR pattern in V1, M pattern there, and a W pattern in V6. We call it marrow for to remember that M V1 and W in V6, marrow, and that's a right bundle branch block. So those are, I think these are quite common ECGs you will encounter in your practices as well. And sometimes you find it difficult to interpret. So remember the 2 words, William and marrow. Does it fit into that? Whenever you see a broad, so, a broad complex ECG, again, usually it's either left bundle branch block or a right bundle branch block. It's important to interpret as well. So because remember, bundle branch blocks also, left and right bundle branch blocks, could mean it is an acute coronary syndrome as well. And it's in the definitions now as well. And again, remember, the history is what is most important. If a patient comes with a typical history of ischemic sounding chest pain with either a left or right bundle branch block, most likely it is an acute coronary syndrome and needs to be sorted out. So let's just talk a few minutes about non-ischemic ECGs as well. I think that's important because those are the ones that, because I think it's important as general practitioners as well to know about non-ischemic ECGs, because that from a patient's point of view as well and your point of view, it's essentially about reassuring them, because sometimes patients come to you with these ECGs, somebody has said it's a heart attack or something, and it's quite common to come to us as well as cardiology. We get so many patients who come to us saying that somebody said, doctor, I got an ECG done and they said I'm having a heart attack. But again, please remember the vital, that piece of advice of the history matters. But and his patients sometimes come to us with what we call atypical chest pains, and they come up with these ECG. So you can appreciate the ECG here that you can see T inversions here in leads V1, V2. So let's, for example, this is a patient, young lady in her 20s or 30s comes to you with an atypical chest pain with this ECG. So this is a so-called female variant, symmetrical. You can appreciate the fact that these are symmetrical T inversions, V1, V2. Again, if you are in doubt, again, the history matters. But if you are in doubt, as I said, the best way to know whether this is a non-ischemic ECG or not, whether it is a female variant or not, you can obviously repeat this ECG in a few minutes and it will be quite identical. So if that's the case and the history is not very suggestive, you can safely reassure the patient saying that this ECG is not a ECG to worry about. Then this is a very common ECG that we get as well with patients who say that they're having a heart attack. They are brought to the hospital saying that they're getting a heart attack. Thankfully, again, this is not something that is we are worried about, and this is so-called early repolarization or J point elevation. So the J point is pretty much the point where the QRL in the S wave and the ST segment joins. And you can appreciate here in this ECG, especially in leads V4 to V6, that J point is elevated. And you can appreciate, you can see that there are ST elevations, I do agree, but as opposed to the ST elevation in my ECGs, you can appreciate the shape of that. This is what we call the concave looking ECG. So that's a concave ECG, which is not ischemic. And this is a so-called early repolarization or J point elevation. And again, remember, the history would have been an atypical sounding chest pain as well. So next case is something different now. Let's talk. We've spoken about chest pains. Let's talk about a different history. We get a 30-year-old lady coming to the GP practice with a history of palpitations. I think that's a very, correct me if I'm wrong, but I think to the general practice, that's a very common history as well, palpitations. The blood pressure is 130/80, but you notice that the heart rate is very fast. It's going at about 150 beats per minute. And ECG was taken. And again, so the first thing that we notice on this ECG is that you appreciate the fact that this is a tachycardia, isn't it? The heart rate is very fast, and obviously when you felt the pulse, it was going at 150. It is a tachycardia. So what type of a tachycardia is this? So the first thing you look at is the QRS complex. Is it a narrow complex tachycardia or a broad complex tachycardia? And you can appreciate the fact that this QRS complexes are narrow. So this is a narrow complex tachycardia. And then we notice that, are we seeing any P waves before the QRS complexes? And I suppose you can appreciate the fact that there are no P waves in front of the QRS complexes, but it is a regular. The QRS complexes are coming regularly. So if I were to give it a term to define this ECG, it's a narrow complex regular tachycardia without P waves. Okay, so regular narrow complex tachycardia with no visible P waves. So this is what we call a supraventricular tachycardia, and SVT, supraventricular tachycardia. So a regular narrow complex tachycardia with no visible P waves. And obviously, this patient should be sent to an emergency unit for treatment. What about this ECG? Same history, let's say patient came with palpitations, and you do an ECG, and this is a little bit more different to that ECG that we saw earlier. Again, tachycardia, you can appreciate. The QRS complexes are narrow. We can appreciate. No P waves, but is it a regular rhythm? No, it's an irregular rhythm, isn't it? So how do we say, how do we define this ECG? It's an irregular, narrow complex tachycardia without visible P waves. So this is what we call an atrial fibrillation, AF. I put that ECG again. Narrow complexes, but irregular tachycardia, no P waves. So this is classical atrial fibrillation. And if you see a ECG like this, again, you need to refer the patient to the emergency unit to be seen by a cardiologist. So these are all, again, spot diagnosis in it. So this is another funny looking ECG. What do we see here? The QRS complexes are not, it's not tachycardic, but I'm just putting this just to for your awareness as well. So again, certain things are what we call spot diagnosis, isn't it? You can appreciate this, the baseline here, isn't it? It's a very funny looking baseline there. So that's a classical sawtooth pattern, as we call it, sawtooth pattern of what we call atrial flutter, where we get a sawtooth appearance of the baseline. Right, what about this ECG? Well, I hope you don't get this type of ECG in your practice, but if sometimes patients do come walking in with this ECG as well. So again, you can appreciate the fact that this is a tachycardia, isn't it? It's the heart rate is going very fast. But if you look at the QRS complex, now we are dealing with a wide complex here on the QRS. So this is a wide complex tachycardia, which is going regularly. It's a regular wide complex tachycardia. So this is what we call a ventricular tachycardia, VT. And sometimes patients' VTs can come in with, coming in walking as well, hemodynamically stable. But there are certain features of a ventricular tachycardia that points towards it. So there is AV dissociation, capture beats, etc. I'm not going to go through this, but if you see this kind of an ECG, a broad complex tachycardia, which is regular, obviously this is ventricular tachycardia, patient needs to be admitted ASAP. Let's talk about a little bit a different history. We have a older man, 75-year-old man, brought to the GP practice with a history of syncope. Pushpa, if you don't mind, give me 2 minutes. I have to plug in my laptop. The battery is coming down, so I do apologize. Give me 2 minutes. I'll get my charger, and I'll plug in the laptop, and I'll come back.
Right. Okay. Okay.
Hi, I'm back again. Pushpa, you can hear me, no?
Yeah, can hear.
Okay. Apologies for the delay. Laptop is all it's on the charger now. So the last case that I will discuss today would be a 75, an elderly gentleman. Again, comes to the practice with a history of recurrent episodes of syncope or transient loss of consciousness. Again, I think it's a reasonably common scenario that you encounter in your practices as well. Blood pressure is okay, but you notice that the pulse rate is 30 beats per minute. So he's having a bradycardia when you're examining the pulse. There is no murmur, because I think examining for a murmur in this kind of patient is very, very important. Those who come with syncope, because you're looking at aortic stenosis. But this patient did not have a murmur as well. But an ECG was done. And this was the ECG. Again, a bit of a scary looking ECG, and you wonder how this patient is standing in front of you, but they do. Sometimes these patients tolerate bradycardias quite well. But what do we notice here mostly? So obviously you appreciate the fact that the QRS complexes show that it is a bradycardia. But what we are noticing here mostly, look at those, but can we see P waves? The answer is yes. Let's take this lead, which is right at the bottom, lead 2. There are P waves. You can see there. However, there is what we call AV dissociation. So you can notice the fact that the PR intervals are changing. So you can see this PR interval there versus that PR interval there versus that PR interval. They are changing. But the QRS complexes, you can see, are coming regularly. They are bradycardic, they are quite slow. The interval between the QRS complexes is very long, you can appreciate. It's bradycardia. However, the QRS intervals, it's bradycardia, but they are coming regularly. But there is a dissociation between the P waves and the QRS complexes. So that is what we call AV dissociation. So when you notice this is what we call a complete heart block or a 3rd degree AV block. So there are different types. So obviously, you have heard 1st degree, 2nd degree. Again, I'm not going to show ECGs of all of those, but the important one not to miss in a general practice would be a complete heart block ECG like this. And the easiest way to identify it would be to notice this AV dissociation. It's a bradycardia where the PR interval varies. So this is a classical ECG of a complete heart block. Right. This is another ECG of a very important bradyarrhythmia to identify. Again, unlikely. Sometimes you may get an ECG like this in the practice as well. But what we notice here, that again, SPR, there is a P wave in certain leads. However, there is a huge gap here, isn't it? So that's what we call a sinus arrest. There is absolutely no conduction for a good 3 seconds probably. So this is what we call sick sinus syndrome, where there is a sinus arrest. There is no sinus beat, and then there's a pause. There's a big sinus pause for about 3 seconds, and then it suddenly starts again. So this is a sinus pause in a part of spectrum of sick sinus syndrome. Again, as I said, there are certain ECG mimics that sometimes worry us. And one of the commonest ones that you will get in general practice is this. You can see an ECG here. Again, majority of the ECG looks normal, P waves and etc. But look at the arrows. Those are the so-called ventricular ectopics or premature ventricular complexes. So very common ECG to get in practice, and a lot of people worry about it and refer as well. And sometimes the cardiac electrophysiologists are the ones who tell this as well, that they say that ventricular ectopics worry a lot of people, but there is actually majority of the time that it's nothing to be worried about, especially if it's infrequent. But sometimes a lot of people refer these patients to us saying that this is a heart block, because what you notice here, you can see the rate here, it's going at about maybe around 100 beats per minute. But then after this ventricular ectopic, you can see there is a bit of a pause there as well. You can appreciate that there is a gap there after the ectopic. And a lot of people think that means it's a sinus pause or sick sinus syndrome or something like that, and refer to as well. But this is a typical ECG where you get these ectopics. We get a so-called compensatory pause after an ectopic beat. So this is not pathological. It's just part of the conduction system. So the conduction system takes a little bit of time to regather and then start producing sinus beats again. So this is what we call a compensatory pause. It's not pathological. Right. So that's pretty much all the ECGs that I have today. I hope your rhythm is not like this at the moment, and I hope that you're all alive and well. And I'm more than happy to answer any questions. I feel that there will be a few questions to answer, and I'm more than happy to try my best to answer any questions that anybody will have. Pushpa, over to you.
Yeah. Are there any questions? Participants, are there any questions? I think there are no questions. I want to ask something, Chamara. Now, there was I think Friday, I saw a lecturer who came with central chest pain and backache also. She was 38 years. She had, T inversions in all leads. So
Okay.
she said that is not, but anyway, we transferred to Kalubowila. But
Yeah.
she said that was normal for her. From the advanced level that she was having that, it seems. Is there any condition?
So again, this if I were to go back to my ECGs that I showed
Yeah.
Pushpa, this
Yes, that's,
non-ischemic
yeah.
ECG, so the so-called female variant, you get the inversion. Sometimes you get it in V leads. In the anti-release, V1 to V3, V4, V5. Sometimes they get it up to V6 also. You can get this T
Yeah,
inversion.
all the leads there, she had the
Yeah.
inversion.
So this could be a typical female variant as well. But again, when in doubt, I think you did the right thing. You send the patient to the hospital. But again,
Yeah,
as I
we
said, the most important is, as I said, whenever you are suspecting this patient may be having an ischemic sounding chest pain, the easiest thing to do, as I said, would be to repeat the ECG. And as I said, if it was ischemia, if you did one now versus doing a repeat ECG in half an hour, there would be something different. Those T inversions would have got deeper, or sometimes the T inversions may have disappeared and now they are not T inversions anymore. It's always dynamic. There is always going to be some sort of a difference between the first ECG and the second ECG if this was a typical ischemic chest pain and acute coronary syndrome. In this patient that you described, I'm pretty certain had they done repeat ECGs, the ECG would have...
she had medical records, but she was lecturing and she was brought to the medical center. So she didn't have any medical records. So we immediately transferred.
They would have done repeat ECGs, and those ECGs would have been identical. So in non-ischemic chest pains and non-ischemic ECGs, when you see these abnormalities, they will not change over time. They will not be dynamic. So that's kind of the one way at least of knowing whether this is ischemic or not ischemic. That's why.
There are a lot of questions in the chat box.
Yeah. You want me to have a look at them myself?
Shall I read it?
Yeah, if you don't mind.
How to differentiate hyperacute T waves?
Hyperacute T waves again are my mouse has got hyperacute T waves are basically mouse has suddenly decided not to work for some reason. These are the T waves that obviously how to differentiate hyperacute T waves from normal T waves, I suppose, is the question. So hyperacute T waves are taller than normal T waves. So the normal T wave is about up to 5 small squares. So any T wave that is more than 5 small squares is considered a hyperacute T wave. You can see on this, and it's the earliest sign of ST elevation myocardial infarction. But again, if you are suspecting and if you are not sure that this is a hyperacute T wave or is it normal or whatever, and you are thinking it's a STEMI, as I said, within minutes that hyperacute T wave will change over to ST elevations. If it is a myocardial infarction, those ECG changes will change over time. So that's the importance, as I always said, the importance of repeating ECGs is that whenever you are in doubt, repeat the ECG. That should be the mantra.
Then regarding starting aspirin and clopidogrel in patients, is there any guideline for it? If not, when should we start?
So again, obviously the guideline is that if you diagnose a patient with an acute coronary syndrome, start giving them antiplatelets as soon as possible is the golden rule, because the earlier you give it, the less mortality, especially aspirin. Even for clopidogrel as well, there is benefits. But the oldest trials have shown by giving aspirin early, it definitely prevents death as well. But again, your clinical history should be, so again, we need to follow the main principles. The patient's history should be suggestive, and you need to have an ECG diagnosis of an acute coronary syndrome, either ST elevations on the classical ST elevations on the ECG, or ST depressions, etc., which I just showed. And if you are confident that this ST elevation is an ST elevation myocardial infarction, and the history correlates as well, giving aspirin and clopidogrel as soon as possible would be the best way forward.
Then there's another question. Does the T inversion common in pregnancy?
I won't say that is correct. I don't think so. I think, again, not necessarily pregnancy. I think, again, females, again, there's a so-called that female variant where there are T inversions, especially in the chest leads, not necessarily because of pregnancy, it's just female variant.
Right. The other question is, in peripheral hospital, we don't have SC morphine. Is it possible to give oral tramadol as a painkiller for acute cardiac syndrome till transfer?
The answer there is no. Tramadol, we don't always recommend. It can cause tramadol. The problem is it can interfere with. It can cause obviously vomiting, and it might. And we don't necessarily give tramadol because it can interfere with the absorption of antiplatelets. So we don't recommend oral tramadol in these patients. That's why we give subcutaneous morphine or intravenous morphine. I know it's a bit difficult in the peripheral hospitals, but in the so we need to try and get morphine or fentanyl or some intravenous medication as far as pain relief in myocardial infarctions are concerned. Oral tramadol is not recommended because it can interfere with the absorption of antiplatelets, and that is far worse.
So, Chamara, there are a lot of questions they are posting. I mean, I don't know whether.
I was telling Sunit as well that I was expecting a lot of questions. So maybe.
So what to do?
5 more minutes. I think we started at
right.
9. We started at 9:15, I believe, because of logging in. So 5 more minutes. I'm happy to answer questions.
Yeah. How do we identify pulmonary embolism on an ECG?
Good question. So there are some common ECG changes of pulmonary embolism. I think the classical one that we read about and we are, I suppose the textbooks say is that classical S1Q3 T3. There is a deep S in lead 1 and a Q in lead 3 and a T inversion in lead 3, S1Q3 T3. But quite funnily that although we read about it and etc., that is actually very rare. S1Q Q3 T3 on an ECG for pulmonary embolism happens in less than 5% of pulmonary embolism cases. The most common ECG change for patients with pulmonary embolism would be a sinus tachycardia. That's the most common one. And sometimes if it is a large pulmonary embolism, you can see changes in the chest leads where we call it a right ventricular strain pattern. Sometimes you get a right bundle branch block on the ECG with a sinus tachycardia. So those are the commoner ECG changes, but that S1Q3T3, if you are thinking about that, it's classical for pulmonary embolism, but very, very rare. It happens in less than 5%.
So another one is if there is a patient with a history of ischemic chest pain and the ECG shows, I don't know, I can't understand, J point elevation, must be one. She has written, she or he had written J point.
Yeah.
At around what time do you want us to repeat the ECG and do they need troponin?
So again, to answer that question, so as we the basis of my talk, as I said, if the history is suggestive, clinical history is suggestive, and patient has certain risk factors like diabetes, hypertension, dyslipidemia, who comes with a very suggestive ischemic sounding chest pain, J point elevations potentially again could be normal. Sometimes patients give a classic history, they would have read about it somewhere themselves or something. So my recommendation would be, yeah, before getting excited, as I said, repeat the ECG. Good question as to where, again, as I said, there is no hard and fast rule when to repeat it, but I normally suggest you repeat in, if it's feasible, 50 minutes or 30 minutes. But even if you repeat it in 15 minutes, there should be some, if it is ischemic, if it is a ST elevation MI and not just J point elevations, there would be some dynamic change there, maybe in half an hour. And I think doing a troponin would be a good idea as well, as long as it falls within that time period. Remember, troponin, the rise takes a while, so maybe about 2 hours after the onset of chest pain, doing a high sensitivity troponin I would be a good idea. But to repeat the ECG after maybe 15 minutes, ideally maybe about half an hour, would be the best recommendation.
So then there another ones in a repeat ECG, if there is only an increase in height of T wave in same precordial leads, is it considered as dynamic change?
The height of the T wave,
The height
meaning,
of the T wave.
okay, if it's not a T inversion and if it's just the normal T, which is a positive T, which is going up, it's not very significant. But what we call dynamic T inversions is that the T inversion gets deeper. But if it's a T that is going up, it's unlikely that it is anything significant. But again, if you notice something dynamic, anything, if it's a T wave, a positive T wave, which is higher than the previous one, again, go back again, same mantra. If the history is suggestive and you're suspecting that this is an acute coronary syndrome in your gut and that your ECGs are changing a little bit, take your time again, repeat the third ECG as well, maybe in 15 minutes or half an hour, and that will give you the answer probably.
So the other question is, do we need to start antiplatelets for patients with a long-term history of diabetes, hyperlipidemia and hypertension? If so, when should we start?
I think we are going beyond the scope of ECGs now, but okay, I'm happy to answer those questions as well. I was thinking the questions are going to be about ECGs. So if you're talking about primary prevention, when a patient who has not had a previous ischemic heart disease history, still there is a lot of debate as to whether to start them on antiplatelets. The risk obviously is, it's again a balance between the benefit of preventing that first heart attack versus the risk of bleeding. And still so far, the evidence is not very clear whether starting them on antiplatelets as primary prevention is beneficial. So the American Heart Association, for example, recommends starting them on aspirin, a single antiplatelet if they have very high risk of getting an acute coronary syndrome. So you do a calculation, you know, there are these risk scores available online. You do a risk analysis, and if the 10-year risk is more than 20%, starting them on an antiplatelet, a single antiplatelet, may be beneficial if they don't have any other bleeding risk factors. So always it's a balance between not allowing your patient to bleed out versus preventing that heart attack. Again, there is not a lot of evidence in other patients, but if your patient has a very high risk profile of getting an acute coronary syndrome, as I said, there are risk calculators online. A lot of people have access to it. They're all free. You do a risk analysis, risk stratification. If the 10-year risk is more than 20%, then there may be some benefit in starting them on an antiplatelet. But in any other patient, primary prevention, there is still no evidence that starting them on antiplatelets is beneficial.
I will ask one because the questions are flooding. I think you have to wait till 12 o'clock, 12 midnight. So I will ask one last question. How do you identify atrial ectopics on an ECG?
Yeah, okay. Yeah, unfortunately, because of the lack of time, I couldn't put an ECG of atrial ectopics. So atrial ectopics, again, if it's from the atria, so that means the focus is not in the sinus node, but somewhere else in the in the atria, right atrium. You will get a abnormal looking P wave because it's atrial. You get a P wave, but it's not so you get the normal P waves in the most of the leads, and the ectopic atrial beat will have a abnormal looking P wave followed by a narrow QRS complex. So the P wave morphology is different. That's how you can differentiate between an atrial ectopic versus a normal sinus beat. The P wave will look different. There'll be an abnormal looking P wave amongst normal looking P waves, which is normal sinus beats, and there'll be an abnormal looking P wave as well.
So thank you very much, Chamara, for the time. We have taken a lot of time from you. I mean, for the very informative lecture and the questions you answered. Thank you very much. So still the questions are flooding. So anyway, sorry that we can't answer.
Yeah, it's always a pleasure, Pushpa, and thank you again for inviting me to do this lecture. But maybe I could give a suggestion.
Yeah, I think better to organize a face-to-face lecture because I mean so many participants, about 300, we had to refuse. Anyway, we are sending all the lecture recording tomorrow to all the registrants. So thank you very much, Chamara, for this informative lecture. So we'll meet again in another webinar or another lecture, face-to-face lecture.
We can maybe try to do a part 2 of this, and I can show a few more ECGs, and as you said, face-to-face where we can ask. And my thing is I like it to be interactive, so that's why face-to-face ones are easier in that sense.
Yeah, so we'll anyway we might in the future we'll arrange another one. So thank you very much, Amar, and thank you very much, participants. I mean, I am delighted that there were over 400 had registered.
And I hope it was
useful. Okay. Good night.
Thank you and good night. Thanks, Utpa. Thank you for organizing. Thank you.